Okay, we will call the Health Insurance and Long-Term Care Issue Committee to order. We will not take a roll. We'll mark everybody attendance present. Good morning. I'm West Virginia Delegate Steve Westfall. I'll be chairing this meeting today. I need a motion to waive a quorum.
So moved.
A second?
Second.
All in favor say aye.
Aye.
Opposed? We'll waive a quorum. Before we get started on our agenda, I'd like to note that the starting of this conference, we're introducing a new testimony process. Anyone in the audience who is not scheduled to speak on an issue can fill out a testimony slip stating that who they're representing and with a position on an issue. The testimony slip can be found at the speaker's table. After completing the slip, you can submit the slip to me or whoever the staffing the committee next to me, and then we will be incorporate into the minutes after the meeting. You can feel free to submit a slip on any issue. It doesn't necessarily have to be a model law or resolution. We're going to kind of move around on the schedule today on your printed material. We'll start today with a presentation of the drug shortage and supply questions. Joining us today is Andrew Barnhill, head of the public policy of IQVIA. Andrew, if you're there, go ahead.
Everyone, really appreciate the opportunity to kick things off today with a topic of general interest to many of us as legislators and across the health sector as a whole, and that is drug shortages. IQVIA is the world's largest clinical research organization. We're also a very large healthcare data organization. And so the focus of my conversation this morning for a few minutes will be looking at prescription data and giving you some observations about trends related to drug shortages. Shortages have been an ongoing issue in the U.S. healthcare system for more than a decade, and it really is something that matters to all players across the ecosystem. One of the ways and data sources that we want to take a look at this morning is the National Prescription Audit, which IQVIA conducts, and it's the industry standard source of all national prescription activity for pharmaceutical products. It measures the demand for those products, including dispensed pharmaceuticals to consumers across three unique channels, and that's retail, mail service, and long-term care pharmacies. And IQVIA, as part of this process, collects new and refilled prescription data daily that represents over 92% of all outpatient prescription activity in the United States. So a lot of these observations are coming from that data set. As of the most recent audit earlier this fall, there are 132 molecules in the U.S. market with an active shortage. And those impact a range of therapeutic areas, everything from pain and anesthesia to oncology to CNS and infectious disease and diabetes drugs as well. And over the past 5.5 years, 3 times as many new molecule shortages have occurred as have been resolved, with those shortages typically lasting more than a year. So that fact right there is really what's leading to a lot of the discussion and concern, if you will, surrounding perceived shortages and actual shortages in the U.S. today. I want to sort of demystify a little bit about what's going on with some of these shortages. First of all, they tend to be in generics. About 84% of them are generic products. And they tend to also be injectable drugs. 67% of molecules on shortage today come from injectables and are more frequently multi-source products. And this is a big difference from even back a decade ago where you were largely talking about single-source products. The market of the shortage concerns largely remains concentrated in a few suppliers, which really impacts the ability to readily resolve those shortages when 1 or 2 leading suppliers is affected. But there are several categories that I think you've probably seen in your research or in news reporting that I want to hit on this morning to give us a closer look at what's going on. One is in the oncology space. So although oncology shortages have really only impacted a small share of overall volume, the inspection-driven disruptions and some market exits have led to significant shortages in older chemotherapeutics and particularly platinum-based ones. So in effect, treatment for some cancer patients has been quite impacted and might be delayed by some of these chemotherapy shortages. And this is why the oncology concerns have really drawn our attention recently. There have also been some mental health molecules that have been on shortage since 2018, so that's not a new thing, with some classes of drugs in the mental health space that have been showing a sharp increase in shortage, largely due to demand in the past 5 years. Another that you've probably heard about a bit recently have been anesthesia drugs. So anesthetic shortages have been really persistent since 2017, driven by a lidocaine shortage. But this is something that has continued, particularly as these medicines became utilized by patients of COVID-19 who were hospitalized, that resulted in some shocks to the supply chain that drove up the volumes substantially during that time and have sort of continued as a shortage to date. Two other categories, one in the antibacterial space. We certainly had a number of public health measures during COVID-19 that disrupted, the normal seasonal pattern of bacterial infections, particularly in children. And we've started to see a return in late 2022 and certainly now in 2023, a return to those normal historic infection levels. And so as a result, we saw a shortage in pediatric, particularly the oral liquid antibacterials, as the pandemic at the same time was resulting in this unpredictable demand. We've also seen that some of these shortages could lead to concerns about antimicrobial resistance, AMR. So we want to keep a close eye on this issue with antibacterials as we move along, because there is more than just domestic concern here. There's potentially some significant global concerns about antibacterials. The final category is one you're probably hearing arguably the most about in the press right now, which is GLP-1s. So the GLP-1 agonists are a novel mechanism, and this illustrates to us, since we're hearing about shortages, that shortages can also affect new drugs prior to the patents expiring. So it's not just something that you're going to see on generics or those that have been on the market for a long time. But this is a little bit of a different issue, and I want to explain the difference here for a moment. So the first GLP-1 agonist for treatment of type 2 diabetes launched in 2005. However, the attention surrounding this class of drugs really spiked since the launch of Ozempic in 2018, and then the subsequent launch of Wegovy as a treatment for obesity outside of just diabetes in 2021. So since that launch of Wegovy, new prescriptions are up 181% for diabetes GLP-1 indications and 257% for obesity GLP-1s in just this very short period of time. So Wegovy, Ozempic, Trulicity, Mounjaro, all the ones currently on market, are experiencing shortages from sort of a different set of reasons. As new patients are demanding access across diabetes and obesity, and we see an outpacing of supply, potentially causing difficulties in filling prescriptions for patients already on therapies. And what you're seeing is a lot of pharmacy hunting taking place with individuals trying to find those products and going out of their normal neighborhoods or local pharmacies in order to get them. So that's a little bit different than the true shortage issues that we're mentioning earlier, such as in the oncology drugs and in the anesthesia drugs. But the GLP-1s have shown significant progress for people living both with diabetes and obesity that's more than doubled since the end of 2020, driven by new patients across those categories. And so this surge is showing us that we are potentially going to see, as new innovative medicines come on market, that some of the initial levels of shortage might become a recurring issue in our pharmacy ecosystem that we have to wrestle with as time goes on. But final takeaways for us in this group today, I think, are one, that shortages can have different causes depending on the market dynamics that are at play, and they require a different set of solutions, a variety of solutions, and participation from all the stakeholders in the healthcare ecosystem, including legislators, to resolve and prevent future shortages from occurring. But we should also think about the shortage environment as one that's requiring a careful balancing of patient access with availability, making certain that we can collectively do everything we can as partners in the healthcare ecosystem to eliminate barriers to patient access, even in the midst of shortage concerns. So hopefully that provides you an overview about some of the different aspects we're seeing in the shortage landscape, and might even elicit more questions for you as time goes on. But thank you again for the opportunity, and happy to answer any questions you might have.
Thank you, Andrew. Do we have any questions for Andrew? None? Okay, thank you for being here today.
Thanks.
Going to back up a little bit. We did not approve the minutes. So I need a motion to approve the minutes for the July 20th, 2023 and October 6th, 2023 committee meeting. Do I hear a motion? Do I hear a second? Second. All in favor say aye. All opposed nay. The minutes are approved. Next on our agenda, presentation from Amazon entry into the U.S. healthcare marketplace. Joining us today is, I'll probably pronounce this wrong, Tanvi Patel, Director and General Manager of the Partner Services at Amazon Pharmacy. Go ahead, Tanvi.
Hi, thank you. Yes, Tanvi Patel from Amazon Pharmacy specifically. Thank you for having me today. I'm excited to come here and share what we at Amazon have been up to in our health services space, and answer any questions you might have. So Amazon Health Services, which encompasses Amazon Pharmacy, Amazon Clinic, and now One Medical also is relatively new, but our vision is very clear. There are, just much like what we do in all of Amazon, we're very customer obsessed. We're focused on the customer, working backwards, a lot of invention, a lot of iteration, a lot of learning, and then investment in the right places to ensure that our patients that are coming to Amazon for their healthcare can trust Amazon for that healthcare, whether it be primary care services through One Medical, digital health services through Amazon Clinic, or getting their medications and staying healthy through Amazon Pharmacy. So I wanted to share a little bit about what we've been working on, the progress we've made to date, and then really what our objectives and goals are in this industry, and then open it up to any questions you might have. Back in 2018, which is probably when our healthcare journey started with the acquisition of PillPack. PillPack is a service that does compliance packaging for medications for patients that are multi-chronic, that may have 2, 3, or more medications to take, and they need packets to make sure that they're taking them when they need to take them, several times a day potentially, and which medications, including potentially even over-the-counter medications they may be taking with that. In 2020, we built Amazon Pharmacy on top of PillPack, which is a multi-service, full-service pharmacy, which serves home delivery of pharmacy, whether it be acute medications. If you need an antibiotic today in several geographies, we're delivering same day or early the next day. Or if it's your chronic medications for maintenance management, which many in the industry have been using potentially for a long time. Getting faster and faster allows us to really serve with convenience where there may be pharmacy deserts, and accessibility and affordability of those medications. Then we launched Amazon Care. Many of you might have heard of that. And we learned from what Amazon Care was in terms of how patients were looking to Amazon for that convenient digital health care. And then we iterated on that and turned it into Amazon Clinic last year. Amazon Clinic is leaning into what Amazon does well in terms of meeting customers where they have needs with providers who can provide those needs. It's a marketplace for digital health. So it serves about 36 or 37 different chronic conditions. It allows patients to come to Amazon, answer a few questions, and then matches them with a third-party digital health provider who can help take care of those medical needs for them, and then go on to prescribe or point them in another direction to make sure that they're continuing to stay healthy. One Medical was acquired in March of this year, which is a member-based primary health service provider. We have about 200 locations across 28 geographies and growing. Just this year, or just last week, in fact, we launched $9 a month for One Medical membership for Prime members. It's about $199 a year otherwise. So all of these combined really allow us to serve our patients and our customers to get care, find care, and then stay healthy. The goals that we have in this space are really around price transparency, ensuring that customers know what they may be paying before they get into it, and affordability and accessibility. So I wanted to speak a little bit more deeply just about what we're doing in pharmacy specifically to these goals. A couple programs that we've launched recently. We launched RX Pass earlier this year. RX Pass is $5 a month for Prime members, and we have about 60 to 65 formularies on the list of generic medications that are available to the members of RX Pass. Unlimited of those on that list, but the formulary is created such that it covers medications that 150 million Americans take today. This has been a very great program especially for Americans who are either underinsured or uninsured, to make sure that they have the continuity of care on these commonly used generic medications if they change an employer, if they are not employed, but they know that they can continue to get the medications they need to stay healthy in those cases. Another program that we launched, RX Coupon. We work directly with manufacturers for manufacturer-sponsored coupons to bring down the price of very popular medications that customers and patients need to stay healthy. For example, diabetes monitors or insulin down to $35. So we'll continue to work with many of our manufacturer partners for these. And as Andrew mentioned, GLPs are another one. We're definitely trying to bring down the price of GLPs as they're dispensed on Amazon to make sure that our patients can get them at affordable prices. Another way that we are thinking about the way folks buy medications in this country is with price transparency. So when a customer goes to Amazon to buy their medications and they enroll with Amazon Pharmacy, or they're working with their physician to say, I would like my medications to be sent to me through Amazon Pharmacy, whether it be today, tomorrow, or 2 days from now, they are able to see upfront what that pricing may be. So we're leaning into technology where we can to estimate the price of a medication that member may pay through their insurance provider. We work with most major insurance providers to make sure that we're serving the majority of the country. Or we might have a price program. So we have a Prime RX program where many generics are 80% off price, and then a lot of brands are 40% off. And then we have the coupon programs in RX Pass. So we're able to expose that pricing to the customers so that they are aware of what they may be paying ahead of time. As we're thinking about more and more what we can do in this industry, we're working with health systems, providers, we're starting with One Medical, understanding what are those customer pain points at that point of care to see how we could help influence the industry to make sure that our Americans continue to stay healthy and get the medications that they need. Thank you.
Okay, thank you. Do we have any questions for our guest? Ms. Patel. Senator Klein?
Hold it.
You have to hold it down. I found that out the hard way.
And maybe this goes back to Andrew because one of the things we hear about the shortages, we're depending on foreign imports. Are we as a country getting behind that and figuring out that we don't want to depend on our foreign, some would suggest adversaries for this basic product that many people are needing. My daughter, the pharmacist, who is suggesting that it's a battle to keep up with the pharmacy, the prescriptions, because they continually are running in short supply. So I guess you talked about shortages. I'm more interested in solutions and how how you perceive the industry moving forward.
Yeah, I can take it. That might be also.
I'll take that as well.
Sure.
We'll both take that.
Yeah. From a pharmacy standpoint, we work directly with the wholesalers and manufacturers here in the United States or elsewhere to make sure that we're getting the right selection of medications for patients. I do agree that we do run into shortages, and it is something that we also are trying to influence in terms of, are there ways to ensure that the customers who need them are receiving those medications and that at the right price and at the right time? You want to speak to?
Sure, and I'll also add to your point about questioning sources of products as well. I think most manufacturers are spending a lot of time and effort right now to diversify their sources of their products and where their manufacturing takes place. And so there's certainly a willingness to adapt. And I think if you look at where manufacturers are basing a lot of their operations and importing now, you've seen some trends shift over the past 2 to 3 years. So I think we'll continue to see some progress there. Yeah.
Any more questions? See anybody? Okay, thank both of you for being here today. Okay, next on our agenda, the consideration the resolution dealing with the health savings accounts. We will be voting on the resolution today. You may recall that we briefly discussed the resolution during our July meeting, and it deals with a very straightforward issue regarding health savings. You can view the resolution on the website and on the app and your brochure on page 56. I recognize Senator Jerry Klein, the North Dakota NCOIL Chairman at Large, and sponsor of the resolution for brief remarks. So, Jerry?
All right, Mr. Chairman, and thank you. And as you mentioned, it's very straightforward. This resolution is just meant to encourage an amendment so that it would be in state law that ensure that when certain types of laws are passed, we aren't inadvertently causing people to lose their access to their health savings accounts. Our state has already enacted this type of carve-out, and the idea is this resolution would help encourage most states to do so. There is an amendment that's been handed out. They've worked that out in the last few days so that everybody is certainly on board. We love legislation and model legislation that when we can get everyone on board. So with that, Mr. Chairman, I encourage the committee to support this resolution. Thank you.
Thank you, Senator. We now hear from Kevin McKinney from the American Bankers Association. So, Kevin, you go ahead.
Yes, good morning, and thank you very much for considering the resolution, and thank you to the sponsors, Senator Klein, Dr. Oliverson, Senator Gossage. We appreciate it. Representative Roberts, Madam Vice Chair, thank you. As Senator Klein described, the exercise here and the resolution in front of you is designed to sit in your state's insurance code and ensure that benefit mandates managed in the insured marketplace, which you manage in your states, coordinate with federal IRS rules, which you don't manage. And that challenge has to be addressed at some point. Just to give you a brief survey of the field, there are somewhere around 45 different bills in the United States Congress addressing health savings accounts. There are something on the order of 750 bills that would impact health savings accounts across all U.S. state jurisdictions. And that field means we have to monitor all of those bills to make sure that they don't propose health benefit mandates that would be in conflict for federal rules, and we do that to protect the people insured in state-managed HSA qualified insurance. And that number of people is large and growing. We insure about 1 in 3 working Americans. The American Bankers Association represents about 95% of all the health savings accounts in the United States. This is tens of millions of people. And I can't tell you exactly how many of those Americans are in insured plans versus ERISA plans. We know that in smaller states that number tends to be higher. We know that in larger states it tends to be lower. We have individual examples in many of your states where a benefit mandate was passed that did not have coordination, and probably a lot of you felt the hand of your state bankers association as they reached out to try to coordinate and solve that problem, which is to say not to oppose, first of all, your right to manage insurance within your state walls any way you wish, and second of all, not to oppose any of the benefit mandates that you may consider meaningful. Our only purpose is to figure out exactly how health savings account rules managed at the Internal Revenue Service can coordinate with your state insurance code. And as Senator Klein pointed out, 8 states have already done that. And they are Arkansas, Kentucky, North Dakota, Oregon, Pennsylvania, Rhode Island, Texas, and Utah. And what we're suggesting is this is very good legislative structure, and it protects the millions of people that rely on insured health plans in your states. With that, I'd be happy to answer any questions you may have.
Do we have any questions for our speaker? No questions? Okay. We will adopt this motion. So I need a motion to adopt the resolution. So moved. Second. Jerry seconded it. All in favor say aye. Aye. All opposed nay. Ayes do have it. The motion is adopted. The model will be presented to the Executive Committee, the final refraction on Saturday. Last on our agenda is some discussion, hopefully a lot of discussion, on the NCOIL dental loss ratio model act. We are not voting on this today. I really wanted to vote on it today, but we are not. Intention is to have some remarks from a couple of people here. I hope some discussion from different colleagues. But my plan is hopefully to have an interim Zoom call sometime in January to vote on some type of model legislation, so we will have something going forward. A lot of us have sessions starting in January and February, different years, different times of the year, so we can have some kind of model plan to use for next year's legislation year. Before we go to the questions, if I could have Chad Olson to come up and also Owen Urick to come up. Thank both of you for being here today. If you would both give us where we are on this, on both sides. This is our third meeting on this. I hope to vote on it, but we're not. So if you would, Chad, you go first.
Yeah, thank you, Delegate Westfall, and hello, everyone. I'm Chad Olson with the American Dental Association, and I'm so pleased that we have continued this discussion. Thank you to Delegate Westfall for pushing the discussion forward. I think the great news is that we've got, I think, some language on the table and in discussion that we can move forward on an issue where the parties are very far apart. As President Deborah Ferguson said in her opening remarks, the best thing about NCOIL is dealing with a tough issue and then bringing it together, balancing the needs of the insurers against consumers. And I think this is an issue that is very pro-patient. We continue to argue that a DLR, a dental loss ratio, will set up the plans to be more valuable if it is established, the DLR established, it will be more valuable, these plans that are purchased. And that, I think, is the end goal. Dental plans that work for the patients and give them coverage that they need. So I know we have some time available for discussion. Happy to keep this brief and talk further. So thank you again, Delegate Westfall.
Okay, Owen.
Well, thank you, Delegate Westfall and members of the committee. I'm Owen Urick. I'm the Director of Government Relations for the National Association of Dental Plans. Again, I want to echo that we look forward to continuing the conversation on the loss ratio model. I know there's been a lot of back and forth and consideration of different options. As we stated in the summer meeting in Minneapolis, we've seen a lot of success in the regulatory framework that was developed based on the language that passed in Colorado. That would create a reporting and outlier remediation structure for dental loss ratio so that your regulators in your state can have a holistic look at a dental plan and the value that it presents. and also use loss ratio in that consideration, but looking broadly at the value of the plan and how people are utilizing it and moving forward from there so that we have a consideration of what that looks like. So that is our position, is that we think Colorado is extremely workable policy, but we are happy to continue the conversation and also think that there's a lot of areas where we can have discussion and build a more positive direction on this language. So again, I'm happy to take any questions as well.
Okay. Either questions or remarks. We first go to Assemblywoman Ms. Hunter.
Okay, keep holding, thank you. Good morning. So we've been having this conversation for a year, and it seemed like we were going along at a good clip, and then we kind of got off track, and then we were going along again. And I was a little exasperated the other day because I'm like, are we curing cancer? The amount of calls and texts and emails that I've gotten about this, and I'm not minimizing that this is a very important issue, but I think that we need to wheel it back here, bring it back, and really identify, and if it's the Colorado model, the Massachusetts model, the percentage model is obviously a concern. Plans moving out of the state because of the percentages. Obviously, we don't want employers leaving. We don't want people to not have coverage. This assessment model, which sounds, great, and we're talking about looking and review and remediation later, that doesn't necessarily solve any of the plans or the dentist problems with getting increased rates until after an assessment. I'm still trying to figure out how we are helping the consumers with access to care, and maybe this is not even the conversation about that, but it seems like dental care is important and equal to health care, and we minimize how important dental care is. So I would like if we could just get back to the basics of what is the problem that we're trying to solve with this model, and then how do we move forward? And I know you've had many conversations. We had an interim meeting. The interim meeting produced a different a model, and then there's subsequent issues after that. So I'm hopeful that there will be other legislators to speak up, but I feel like we've gone down this rabbit hole for a year, and we're back to kicking it down to another meeting, which is fine because we want to make sure we have the best model possible, but those are the concerns I have. I don't want plans leaving states. I am concerned. This Colorado seems like a great compromise, but again, that doesn't help with the increased rates for the dentists. And we can't have all things for all people, of course, but I'm worried about consumers not getting the access to care that they need and out-of-pocket money that they're paying for dental. And it's Medicare reimbursement or re-enrollment time, and I don't know how many commercials you see every 5 minutes on TV about, and you can get dental care, and the only dental care you're getting is fillings and cleanings and 1 exam per year. I feel like that bigger conversation actually needs to be had in addition to this. So I just went a long way in saying I think that we need to just get back to basics with this legislation and see what is the problem we're trying to solve, and we can't be all things to everyone, and I'm very concerned about employers leaving, consumers not having access to care, and obviously the dentists getting the reimbursement that they deserve. Thank you.
Next, we have Representative Matt Lehman.
Thank you, Mr. Chairman. Kind of a little bit what Pam's bringing up, and that is kind of we seem to be going around and around on this issue. And I know when we were in Minneapolis, I think I asked this question. I got hit in the head in September, so now I need to kind of go back over all this stuff. What medical loss ratio, when we talk about medical loss ratio, I guess I go back and think when that term's thrown out during the whole Affordable Care Act debate was, you're going to have medical loss ratio. It's going to help the consumer. It's going to put more money into the pocket of the providers, et cetera, because we're limiting what the carriers can hold and pushing everything else out. The problem I saw on the healthcare side was we went from having probably 15 companies that would write health insurance to 2. And now they have just become behemoths in the industry. So how do we make sure that we're controlling not putting our finger on the scale of the market and allowing, I don't know how many members you have in your health plans. You know, are there 22 companies that will provide dental coverage, or is there 8 or 2? And so the medical loss ratio is going to have an impact on those members, which the end result is we do want to put, quote unquote, more money back into the pockets of the consumers and the people providing the services. But that balance concerns me as to what happens if that medical loss ratio, as it has done in the medical world, forces out the competition.
Delegate Westfall, would you like us to respond to Representative Lehman?
Yes, go ahead.
Okay, thank you. Thank you for the question, and thanks to Assemblywoman Hunter for her comments as well. I think that the view of the ADA is that competition right now between dental plans is predicated only on providing a low rate quote to employers, and that is not to the benefit of the end users, the patients. Competing around the true value of the plans, MLR is one way to get there. I think where we're kind of, Assemblywoman Hunter's point, I think where we're heading is giving some flexibility, saying to set an MLR, and each state would be able to determine what it should properly be to balance some of the things you're talking about, Representative Lehman, without saying it has to be this. And that's why we're open to a discussion about percentages being determined by the state instead of necessarily being mandated. And I think that would address some of your concerns as well, Assemblywoman Hunter. So I think that's kind of where the conversation is going on the compromise side, from our view. Again, one more last thing, with the focus on competition benefiting patients at the end of the day, and not just employer prices. That has resulted among the industry in a race to the bottom. If your only point of competition is to keep the rates low for employers, you're not providing a good benefit. And that's why dental coverage is different. Thank you.
Well, I think to offer a little bit of perspective, but I think where there's some opportunities for us to have some alignment is to say, you know, if regulators through this process, through language that we can develop at NCOIL or based off of what other models have been proposed, we can look at all of the value that a dental plan is bringing to somebody, that you have loss ratio as part of that conversation. That's important, but we are also extremely concerned about what the impact is going to be on competition. We've seen what's happening in Massachusetts, and they haven't even finalized the regulations there yet. We have 5 plans already at this point leaving the small group market. And, you know, I think speaking to a little bit of what Chad said, you know, it is true that when dental plans are quoting a price to an employer, when they are bringing those benefit options to them, those employers are dealing with their narrow budgets and trying to provide dental coverage to their employees to make sure that they can get the care that they need. And ultimately, we want to have a conversation about value, but also we know that from just the studies that have been done and from the market experience that people are extremely price sensitive on their dental benefits, and you know, we want to make sure that that's protected. We want to make sure that the premiums stay at a place where people can afford them, and that moving forward, people are able to utilize the care that they need. I think that's the ultimate goal for both of us, is that people get the dental coverage or get the dental treatment that they need and they can stay healthy. Oral health is incredibly critical to overall health, you know, as Representative Hunter said earlier. So I think that's our added perspective on that.
Representative Ferguson. You have to hold it down.
Oh.
The whole time you're talking.
Okay, thank you. You know, as a person who's all about compromise, I think for us to get to a reasonable model bill, maybe both of you have to be unhappy at some point. I mean, obviously, the dentists want a Massachusetts model where you're actually putting in DLR percentages that are 80% or something. The dental plans don't want any percentages put in the bill. I guess I would like to see you get together and both agree to be unhappy, and that the compromise that we've looked at is not only reporting like Colorado does, but to also, after a 3-year look at all that, for the states themselves to decide what those DLR percentages are. That will give states time to look at the data. It will give them time to look at what other states, how those outcomes have been in different states that have already passed legislation. I just don't understand why that wouldn't be a reasonable compromise for both of you. I know neither of you will be happy. You're not getting everything you want, and you have to go back to your membership and say, I compromised, and this is our model bill. But as we said, NCOIL is all about state regulation, and by allowing the MLR, DLR to be set by the states, I think that's a very reasonable compromise.
And to your point, I think we are absolutely open to compromise and discussion on this issue, and I know that there's a lot of room between NADP and the ADA on a lot of these issues. But I think we've made progress, and we're happy to continue talking about that. And I know getting into the nitty-gritty of those details is one of the things that we're going to need to do.
Senator
To quote
Lang.
Ghost, ditto. So.
Let's go to Senator Lang first.
Have to hold it? Perfect.
The whole
Thank you,
time.
Mr. Chairman. I appreciate it. My question is really a follow-up on what Pam and Matt asked. I appreciate it. Pardon me for a second. My phone rings. It goes straight to my hearing aids. Wait till you guys get old. You'll be going through the same thing. Well, hopefully not. Pam asked a great question. What is the problem we're trying to solve? And is it a problem created by legislators, or is it a market-driven problem? And I think it's fair that we consider the impact on consumers. I think it's incumbent upon us to do that, but it is equally incumbent upon us to consider the impact on the industry. And, I don't want to do anything that is going to harm the industry. The more we try to turn the industry into a commodity, and that may not be a fair analogy, but the more we try to do it, the more we're going to drive out innovation, the more we're going to drive out competition, and I'm worried about the unintended consequence of driving prices ultimately higher if in fact that occurs. And I'm also concerned about the fact, as Deb pointed out, this only impacts states regulated companies that are regulated by the state, not those that fall under ERISA. And are we in fact going to put small employers at a huge disadvantage if the states are regulating in a way that the plans that fall under ERISA, the self-funded plans, the large employers, are not? And what is the long-term negative impact this is going to have on the industry, and how that may translate into a negative impact on the consumer? I'd appreciate that perspective from the dental plans on that.
Owen, you'll go.
Oh, yeah. Well, I think, building off some of the things that we've said already, we want to make sure that anything that is passed through NCOIL is looking at the value of a dental plan holistically in the activities that it's doing. We've talked a lot about Colorado at this meeting and also at the previous meetings. I think our endpoint is if we're creating a model that is showing the demonstration of value, that, loss ratio is not the end-all be-all in that conversation that is going to be had with regulators, with legislators. So I know there's a lot more dialogue to go on that, but I think that's one of our priorities, is to make sure that's part of the conversation.
And thank you for the question, and thank you for bringing it back to Assemblywoman Hunter's key question, which is, what's the end goal? I think the end goal is to create an environment where the plans are serving the consumers more than the employers only. And that's, as I said earlier, that's where competition, you asked, what's the situation? Why is this occurring? I would go back to my earlier analysis that competition is not redounding to a good benefit to the consumers. Right now, the plans, as I've said before, have $1,000 to $1,500 annual maximum. And then the consumer pays out of their own pocket. And that has not changed since the 80s. That is what competition has produced. So I think that, as Owen said, there's a lot of options. What DLR does is it forces the conversation to be more about how do we provide value for patients. And then the last thing I'll say about plans leaving Massachusetts, the history of the Affordable Care Act shows that while plans may have some initial changes to their structures, et cetera, considerations on whether they can continue to pursue a market, we've also seen that they've been successful, the major medical plans, under the auspices of a dental loss or a medical loss ratio. Because I know the industry on the dental side pretty well. I know it's peopled by smart people, and I know that they can innovate. And there was an article that wrote about Guardian, I think, leaving in a certain segment of the small group in Massachusetts. In that same article, there was another plan saying, we're ready to take up the slack. And I think that that's the beauty of the industry, as you talked about innovation. Once a good floor is set that is going to redound to the benefit of consumers, I'm confident the plans will respond in kind. Thank you.
Just a quick note on the ACA. I think something that's worthwhile to point out is that when the ACA passed medical loss ratio requirements for medical plans, that was a barometer for the other reforms that were done in the ACA, which were the essential health benefits and the employer mandate, which expanded the scope of medical coverage and drastically changed that market. And then the loss ratio was kind of one of the barometers that the regulators were using to look at the effects and the requirements and the compliance from the medical plans. That's one of the reasons that the loss ratio was included within the ACA, was to measure those others. I think as we've discussed at some of these other meetings, dental still is a voluntary benefit, and it's something that, there's lots of price sensitivity. You don't have that same requirement for, complete and full coverage, and that drives the market factors for why people are buying dental coverage and what employers are looking for in them. The other thing, I think I'll just share one last thing about Massachusetts, and there's all roads lead back to Massachusetts in a lot of these discussions, I know, but we're concerned that, yes, there may be one plan that hasn't entered the market yet in Massachusetts that may be looking at it, but 5 plans leaving in the market, plans that have those experience, that have been working with those brokers and those small businesses. We heard in the regulatory hearings for the implementation of this loss ratio that businesses in Massachusetts are really concerned about what their prospects look like for their dental plans in the state. And we want to make sure that there's not a harm to access there.
Senator Hackett.
Yeah, I appreciate it. When you look at the thing, and I appreciate George and my friend from New York, but one of the things to remember is, we can't solve a problem because it's a problem the way we try to solve it in medical. What is the greatest thing? Ask dentists. What is the greatest thing about dental plans? And they'll tell you, it's the preventative benefit. We don't have preventative. We've been promised preventative benefit for 40 years in healthcare. All they do is pay claims. But we have preventative benefits. And the dentist will tell you the greatest thing about the dental plans, it forces them to go every 6 months and develop a preventative benefit, the cleaning and the situation like that. On the other side, I can see where the dentists want a better reimbursement because of the limited reimbursement. We understand the problem there. I'm okay with the Colorado plan, but I don't want to be forced into a decision at the end of 3 years. I'm not sure that the medical loss ratio will solve any problem, and it might drive companies out of business. So I think, and I've worked on Steve, I think the may and shall words should be changed where they may do it in 3 years, but they're not required to do it in 3 years. But don't destroy, and I'm surprised you haven't said that, but don't destroy the difference in dental care versus health care. You do provide, preventative benefits where health care doesn't, and it makes people healthier. It makes people have less cavities and less crowns and whatever. So that's the only thing I say is, I know it's a tough problem to solve, and we don't want to run companies out of business, but be careful. Dental, and I've done dental and medical care for years. It is totally different animals under that. The cost is so much lower in dental. So I can see why the plans would be upset by forcing a loss ratio on them, because I do not want to see less people going to the dentist. That would be the worst thing that can happen, and this may cause that.
So if I could respond, thank you for the question, Senator Hackett. So first, on your preventive argument, if there is a medical loss ratio set, That would mean that the plans were incented to encourage people to go to the dentist. Currently, even people with coverage, only 50 to 60% of them ever access their dental plan. If you have a medical loss ratio, suddenly those plans are incented to encourage their subscribers to go. You can see this occurring on the Medicaid side. Currently, according to federal regulation, on the Medicaid side, an MCO is required to meet an 85% medical loss ratio. We know from experience that dentists have in the states that those MCOs, the companies that usually administer them, are encouraging subscribers to go get preventive care because of them having to meet the medical loss ratio. We also see from the California data that there is no incentive to change the MLR over time, no trend. This is reporting only. So I would say the answer to your question is, yes, the plans are concerned about this. I think they are always concerned about reforms and will always point to this is going to hurt our business. Balancing the consumer's needs and getting a better value is so important. And the last point I'll make, and I know Owen probably will want to speak, is yes, preventive is important, but these plans, again, are providing sometimes no coverage really beyond 2 cleanings and one restoration. And then it's nothing more. Medical loss ratio changes the incentive game. It says we have to now meet a medical loss ratio that's really aimed at getting people to good oral health. And that should be the goal of everybody. I hear your concerns on the business going, or the businesses being destroyed. I just don't buy it. I think that there's, as I said about Massachusetts, there's going to be probably some consideration of we need to look at our business model and how we can exist. And then I think just the same thing that happened with the Affordable Care Act, there'll be people coming back into the market, coverage being better. And the last point I'll make is great dental coverage provided by 3 carriers versus not great coverage provided by 7. What's better at the end of the day? I think for consumers to have those 3 options that are better. Thanks.
Just a couple of comments on that. I think I want to echo your point that the preventive benefit that is included within dental plans is critical to the structure of it, and that I know that, even speaking outside of the MCO market where you have the different requirements related to, being part of a government program, that within the commercial market, there is a lot of activity that these plans go into, making sure that they are incentivizing folks to go get care, to go get their cleanings every 6 months, because that saves them money in the long run, and that keeps their teeth healthy and that keeps their body healthy. Frankly, a lot of those activities that would be utilized would be considered potentially an administrative cost under some of the loss ratio requirements that have been proposed in some of the states that we've raised concerns about. Particularly in Massachusetts, there's been a lot of back and forth about plan activities, trying to make sure that people are utilizing their care. So I think what we want to do is make sure that the market stays healthy, that there are other areas that are being looked at the value that a dental plan is covered. I don't think that it has been borne out that raising the dental loss ratio for a plan necessarily intrinsically leads to somebody utilizing care more. It doesn't necessarily mean that the plan is going to provide a richer benefit. There are plenty of other things that they may potentially do. They may cut costs on some of these activities that are beneficial to people in their plans to make sure that they're utilizing care, because they would be disincentivized to do so under some of the loss ratio proposals. I think we maybe need to decouple the conversation from saying higher loss ratio equals better value. I don't think that that's the case. There have been a couple presentations to why that has been given to this committee about what dental plans do and what they offer and what coverage range looks like for different types of dental plans that may be impacted by this. But again, that gets back to having a broader conversation about what structures for the market make sense.
Can I have a question? Should or is the broker's commission included in that medical loss ratio?
So currently, broker commissions, I believe, would be included as an administrative expense in the denominator of a loss ratio. So it's not something that you could count towards a medical loss ratio or a dental loss ratio. And that's the case in, as far as I know, all the states that have passed a loss ratio bill to this point.
Should it be?
It hasn't been included up to this point, so I don't think that it's something that has necessarily been discussed, but it may be part of a later conversation.
Yeah, if I could add to that, Delegate Westfall, yeah, I think that there could be some discussion. That could be a point where, for example, and I don't want to just, I'm throwing an idea out, Owen, I don't know, hold me to it, right? But if there's a way to maybe, instead of it being counted as paying out for care, we want to keep this, if a medical loss ratio is instituted, we want to keep it that the numerator, which is the claims paid out, remains truly claims paid out. But if there was some sort of deduction from the denominator on premium collected, then that could be, and that would allow plans to more easily meet the medical loss ratio while keeping the agents remunerated.
Right, and we already see deductions from the denominator on, state taxes and fees, and there's also, based on the ACA precedent, there's activities to improve care quality that are added on to the numerator in most of those instances, because those are the types of things that benefit consumers.
Maybe more questions?
Can I follow up on that last?
Yes, Tom.
So if I could just follow up on the chairman's point a little bit for clarification, because maybe I see a nugget here. And on the medical, if you don't know this on the medical side, that's fine, but it's been 12 years since we wrote these regs when I was in the NAIC. Things like nurses' helplines and stuff, they're denominator issues, but they count because they reduce the other part of the denominator, right? Am I right on that?
Mm-hmm. Yeah, that's my understanding.
Yes.
And so the argument would be that since so many people don't have dental, including broker fees in the denominator would be an access to care issue. So it would make sense to include it in the denominator to address the access to care issue. Is that kind of what
I think
maybe you both could reach a compromise on?
I'd be open to a further discussion on it, yeah.
Absolutely.
Okay, if there's no more questions, my goal, my intention is to have an interim meeting sometime in January and vote on either the new improved version, or the Colorado version, or whatever we can come up with. I'm going to introduce the Colorado version in West Virginia in 1st of January just to have something to work off of. I think it is important and stuff, or I wouldn't have been the sponsor of this and stuff, on this bill, this resolution. So anyways, if there's no more questions.
Thank you, Delegate Westfall, for this conversation. I hope everybody's enjoyed this edition of Crossfire on dental insurance. Maybe there'll be a sequel, maybe not.
I hope for Assemblywoman Hunter there is no, I don't. Thank you all for your consideration and happy to answer any further questions you may have. Thank you again, Delegate Westfall, for sponsoring the conversation. Thank you.
Thank you.
Do we have any more business to come before the committee? Deborah Ferguson, yes.
Somewhat related, since ERISA was brought up, for the new members and maybe members who don't know, we just went to D.C. and advocated for a waiver in the ERISA process. As most of you know, we have waivers for Medicare, Medicaid, the ACA, other federal programs. And, ERISA really continues to undermine state-based insurance. So I think it's very reasonable that all of you, when you talk to your congressman, that you advocate for a waiver for these ERISA bills, particularly for state-based plans that only have state employees in their self-insured plan, to make sure that they abide by all of these laws that we fight so hard to pass to protect consumers, just as a side note.
Any more questions, remarks? Before we have a motion to adjourn, our next session is on artificial intelligence. It is in this room. It will start at 11:30. I've been advised it might start a few minutes early because we are getting done about a half an hour early. So to have a motion to adjourn, second. All in favor say aye. All opposed, nays. We are adjourned. Thank you, everybody.